Good evening, everyone. My name is April, and I am one of the donor-funded advisors for He Who Laughs, and I want to thank each of you for joining us this evening. We are going to go ahead and jump right on in, and I would like to take a moment to introduce our presenter. Dr. Craig Shimasaki is a co-founder and CEO of Molecular Labs, a neuroimmunology precision medicine company focused on identifying underlying roots of neurologic, psychiatric, and behavioral disorders triggered by an autoimmune response. Dr. Shimasaki started his career at Genentech and has been in the biotechnology industry for over 35 years. As a scientist, his work spans all stages of research and development from bench to bedside. His research included the epitope mapping for an HIV vaccine, genetic breast cancer risk prediction biomarkers, a rapid influenza diagnostic and therapeutics for infectious disease, neuropsychiatric disorders, and noise-induced hearing loss. As a business person, he co-founded multiple companies and led multiple products through the FDA approval process and is a co-inventor on multiple patents. Dr. Shimasaki received his BS in biochemistry from the University of California at Davis, his PhD in molecular biology from the University of Tulsa, and his MBA from the Northwestern University Kellogg School of Business. He is an adjunct professor at the University of Oklahoma and teaches biotechnology entrepreneurship. His passion is to help translate scientific and medical discoveries into acutely needed products to help individuals live better lives. Dr. Shimasaki, thank you for joining us and spending the next hour or so helping us better understand this very special topic.
Thank you, April, and it's great to be here with you and those listening. So thank you to He Who Laughs and your foundation for helping to support this and also being such an advocate for this very important condition that we're going to talk about. So we're going to talk today about molecular mimicry. It's a strange term, but it helps explain how infections can trigger autoimmune encephalitis and other types of neuropsychiatric symptoms. And then we're going to share how the Cunningham Panel can aid in diagnosis and treatment of these various conditions. So with that, I'm going to see if this will work. Okay. My disclosure is I'm the co-founder and CEO of Molecular Labs, and we do perform the Cunningham Panel, but any of the testing data that I'll share with you today will be from peer-reviewed published journal articles and even current research that we're doing in the laboratory. My disclaimer is the webinar content is for informational purposes only, and of course, it's not intended to provide as a medical diagnosis or any advice for medical treatment, and that really should come from your healthcare provider. So we'll get started. And I would like to dedicate this talk to the memory of Isaac McMillan, who is the person who this foundation is named after, and thank April and John McMillan for all that they're doing to help bring hope and healing to thousands of lives in the future. So today what we're going to cover are the inherent difficulties in the diagnosis of these neurologic, psychiatric, and behavioral disorders, and then also what is molecular mimicry and why certain infections tend to be found in patients that have these autoimmune neurologic and psychiatric disorders such as PANDAS and PANS. We'll talk a bit about that, neurologic Lyme, and even long COVID, which you hear a lot about in the news today. And then we're going to talk about how the targets in the Cunningham Panel can be utilized to help diagnose and direct treatment to patients with these various types of immune-mediated neuropsychiatric disorders that are triggered by an infection. And then we'll briefly touch on some of the treatment and the therapeutic modalities that have been shown to have clinical effectiveness in treating these various types of what we'll call autoimmune encephalopathies, secondary to infectious disease. So with that, let's start here in what is the issue here, in that almost 800 million individuals worldwide suffer from a whole host of what we diagnose and call and place into these categories of neurologic, psychiatric, and behavioral disorders. And they vary according to a whole host of different types of symptoms, But there is some commonality between all of these, and that is that they're all diagnosed and classified by symptoms and not etiology. When we say etiology, we mean what is the underlying root cause? So these various symptoms here that you see, and there's just a handful, but there are many different symptoms and heterogeneous symptoms, and they make up different types of criteria for these diagnoses. So for instance, if an individual has motor tics and vocal tics for more than 12 months, by definition, those individuals can be diagnosed with Tourette syndrome. Individuals that are suffering from hyperactivity, anxiety, irritability, aggression, rage, and without any other types of causal contributions, they could be diagnosed with ADD or ADHD, and the list goes on. The point being is these diagnoses are symptom-based rather than what is the underlying root cause, or at least what is the etiology or presumed etiology of what's triggering these. And we believe that medicine will be changing, but the standard of care for various types of neuropsychiatric disorder is focused on treating symptoms and then coping. Psychotropic drugs are very highly prescribed for very large numbers of individuals, and they are also very effective in certain situations. When that doesn't work, there is psychotherapy, and even as a final resort, there's the institutionalization of individuals when they aren't responding or don't respond to these psychotropic drugs. The other thing we find is that even though this is older data, literally hundreds of millions of prescriptions are written for various types of psychotropic drugs. And again, I mentioned that there is effectiveness for certain types of conditions that are truly psychiatric in nature. The other concern is that suicidal ideation and rates continue to increase with the use of many of these different drugs, and that's why the FDA lists many black box warning on some of these drugs because of the potential side effects. The other condition that creates an unintended problem, and that's the segmentation through medical specialization and then the resulting segmentation of care and treatment of patients. For instance, psychiatry is separately practiced from immunology and neurology and infectious diseases, whereas we do know and understand that the integrated view of disease biology is that infectious disease can also impact psychiatry, which impacts neurology, which also impacts neurology and immunology. So if a collaborative and integrative medical care continuum can be undertaken, it can accelerate the diagnosis and treatment of these complex chronic disorders, which we're going to talk about today. This is a survey that we conducted, and there were over 1,000 parents of patients with PANDAS and PANS, or presumed PANDAS and PANS. And this was just one of the write-in questions of a portion of all of these that will give you an idea of the suffering and the pain that goes on with patients, families, and parents and children with PANDAS and PANS and very similar types of infectious autoimmune encephalopathy. And so we are working on a manuscript to help identify the burden of care and to bring to light a little bit more about what it is as far as both societal and financial impact on parents with children with these disorders. The good news is that we see amazing recoveries when patients are properly diagnosed and treated. This is just one of Adam, who was diagnosed with ADHD rather. They also thought that he had autism based on certain symptoms. They were considering institutionalizing him because they were unable to continue to care for him and find treatment that would be effective for him. They did find out about our laboratory, and we tested him. He received proper treatment, and now he is completely well. In fact, this was many years ago, but his mother more recently sent us a picture of him running cross country in high school. She said, recovery is possible. He's 10,000 times better. So let's move over to the discussion about molecular mimicry and why certain infections tend to be identified in patients with autoimmune neurologic and psychiatric disorder. such as PANDAS, PANS, neurologic Lyme, and long COVID. So molecular mimicry can be seen in nature, where there's different types of camouflage that's involved in trying to mimic certain types of conditions or situations or images. But what we're speaking about is molecular mimicry that has to do with infections that may induce autoimmunity. So molecular mimicry is known to occur when sequence similarities between foreign and self peptides or foreign and self proteins in the body result in activating these self-reactive T or B cells, and also then create antibodies that are directed against our own body. So how does that occur? Well, there are 20 letters in the protein alphabet. You can see that here with the GALM, which represents glycine, alanine, leucine, etc. And these are arranged in different orders to produce the various proteins in our body and the receptors, including in our brain, various types of different proteins throughout our entire body. And at some point, there is a sequence commonality between those particular letters or the protein alphabet and, let's say, infectious diseases or an organism or a part of it. Not the entirety, but a small portion of it. And that is what we call an epitope. So an epitope is just a portion of protein, or really a target, in which an antibody is directed against. In this case, it's directed against a portion of this bacteria. There are many parts that antibodies are directed against. Just so happens that we're going to focus on this one portion that a single antibody is directed against. But let's say that particular sequence is also identical to a sequence that's identical to it in a neuron in our body, in our brain. Well, once that antibody is directed against that part of the bacteria, then that antibody is going to cross-react with the same peptide or a similar sequence of the peptide. And we call that molecular mimicry, or an autoimmune response through molecular mimicry. So in simpler terms, if you kind of think about this as friendly fire in the wartime, where when far away, our troops cannot be distinguished maybe from enemy troops, and the strongest forces that we have in the military are then directed against our own troops. This is analogous to what we think of in autoimmunity and non-self discrimination that goes awry. And this is what we call various types of autoimmune disorders, different targets. There is a genetic component to this. It's a predisposition, or at least a susceptibility, we'll say. And that susceptibility has to do right now with an understanding that there are MHC, or major histocompatibility complex loci, in the HLA, or the human leukocyte antigen class 1 and 2, that seem to carry susceptibility to these types of non-self dysregulation. This is why you may see, and typically you do see, a family history of some type of autoimmune dysfunction in patients with immune-mediated neuropsychiatric disorders. It could be family history that maybe is a couple generations back, but typically you will see some type of autoimmune dysfunction in the family history. So molecular mimicry also occurs between the strep bacteria and self-antigens. In fact, this has been very well described and studied. So you just look at the strep bacteria here. If you take a closer look, the cell wall is comprised of what we call these group A carbohydrates and M proteins. And this is what is at the outer surface of the bacteria, of which antibodies can be and are directed against certain portions of these targets. However, we also know that there's some molecular mimicry between the M protein in streptococcal bacteria and the heart valve, or proteins within the heart valve. We also see that there's some molecular mimicry between a part of the brain, which is called basal ganglia. And then we also see that there are some molecular mimicry between parts of the joints and this M protein, as well as some portions of the kidney. So what does that mean? Well, there are, as I mentioned, sequence homology between many different organisms and parts of our body. this is one that shows that there is sequence homology between Borrelia burgdorferi, which is the causative agent of what we call Lyme disease, and what's known as the outer surface protein A, which is a particular protein that is protruding from the surface of the Borrelia burgdorferi organism. The interesting thing here is what they found is that there's sequence homology between the M protein of streptococcal bacteria, just like I showed you previously, and the outer surface protein of the Lyme disease bacterium, what's called the outer surface protein A. So what does that mean? Well, if there's sequence homology between that and the M protein, then it's very likely that Borrelia burgdorferi or Lyme disease can trigger very much similar symptoms as what you find in patients that have these molecular mimicry and markers, or these commonality between these autoreactive antibodies from strep. Could also be and do the same thing for patients that have Lyme disease. And indeed, you do see that clinically. So the journal article here said that these particular cross-reactive components of strep pyogenes, the M protein, both which share sequence homology with Borrelia burgdorferi, outer surface protein, suggesting a role for molecular mimicry in the generation of these antibody reactivities. So again, remember, when antibodies are directed against a portion of an organism that has similarity to another portion in the body, they can cause cross-reaction. Now, I won't go into this today, but normal immunology and our body recognizes these and begins to downregulate them in what we call self-non-self regulation and through central and peripheral tolerance. We won't go through that today, but this is also part of the reason that genetic susceptibility plays a role in this. So medical journals are also showing that there's a connection between neurologic, psychiatric, and behavioral disorders. Again, in March of 2019, Frontiers in Psychiatry published and showed this roadmap, the infections being connected to anti-neuronal antibodies, which we'll talk about in the Cunningham panel, and psychiatric disorders, chronic inflammation, the microbiome can play a role, psychological stress, the susceptibility from the genes, T-cell, B-cell dysregulation leading to autoimmune diseases, but also to immune-mediated neuropsychiatric and behavioral disorders. So additional and other journals such as JAMA Psychiatry, we know that over the past 30 years, medical research has demonstrated a connection between these infections and neuropsychiatric disorders. In fact, in March of 2019, they published a study that was over 1 million individuals that were followed from birth to age 18. And the study showed that if a patient was hospitalized for a severe infection, that the risk of developing mental disorders increased by more than 80% for a diagnosis of schizophrenia, autism, OCD, ADD, ADHD, personality behavior disorders, and many others. So in an editorial, the authors concluded, how could exposure to infections affect the brain mechanistically to give rise to mental disorders? They said circulating autoantibodies that enter the brain via a compromised blood-brain barrier and bind to neurotransmitter receptors is a potential explanation. And this mechanism has been proposed in PANDAS and other mental disorders. And we're going to talk about these neurotransmitter receptors and the autoantibodies that cross the blood-brain barrier. And indeed, we'll talk in more detail about the symptoms that are associated with this. And molecular mimicry is not new, and there are other infectious associations with molecular mimicry. Guillain-Barré syndrome has been associated with an infection by Campylobacter and many others. Sydenham chorea, we also know, is a group A streptococcal etiology. Epstein-Barr and lupus, MS and myasthenia gravis, and many others. Myocarditis, cardiomyopathy, group A strep can also trigger that. Diabetes type 1, psoriasis, and the list continues to go on. So neuropsychiatric symptoms triggered by infections are not new or rare. Back as far as the 1800s, Sir William Osler described these bizarre and percipitive behaviors of children with what they called chorea minor and OCD and symptoms of Sydenham chorea. It was also known by another term as St. Vitus's dance, and that's because there were these abnormal, uncontrollable movements, loss of fine motor control, and then loss of even emotional control. So we now know it's a group A streptococcal infection in which antibodies are directed against the heart valve, as mentioned with the M protein, but they also have commonality or targets within the basal ganglia, which contributes and leads to what we call Sydenham chorea. An interesting quote by Harry S. Truman: "There's nothing new in the world except the history you do not know." So we don't have to go back too far to see that there is a repeat of a lot of this information that is being recognized even now as quote unquote new. Well, certain infections are more frequently found in patients with autoimmune encephalopathies and neuropsychiatric symptoms, and the list is here. There are more, but these typically are associated with, I mentioned, group A strep, and we'll talk about PANDAS, influenza, varicella, mycoplasma, Lyme, Babesia, Bartonella, Coxsackie virus, and even others. And typically patients will have more than one infection, and there may be a reason for that. And as the immune system becomes more susceptible, other infections tend to show up, but these typically show up, and then there are others. So we're going to move over to talk a little bit about the nomenclature because it is important, and sometimes it can be a little confusing. So PANDAS, as we'll briefly talk about today, is pediatric autoimmune neuropsychiatric disorder associated with a streptococcal infection. However, there are other microbes, as mentioned, like Lyme, Mycoplasma, Babesia, Bartonella, viral infections that also contribute similar immune-mediated neuropsychiatric syndromes. And it's now known also that there are potentially environmental and other biological factors, things like mycotoxins and mold, heavy metals, other things that may contribute to it or maybe even participate in it. So we have two types of triggers. One is an infectious trigger. The others are non-infectious triggers, but they're similar in the etiology and how the pathology of it plays out. So in 2015, a group of physicians and scientists met together at Stanford and coined the term PANS. PANS actually includes PANDAS and is pediatric acute onset neuropsychiatric syndromes, which includes other types of organisms and even the potential for environmental and other biological factors. Another term has come up, ANDL, autoimmune neuropsychiatric disorder associated with Lyme, and typically this is seen in adults. Sometimes it's called adult neuropsychiatric disorder associated with Lyme because PANDAS, by definition, does not include adults. So therefore, an adult technically can't have PANDAS or PANS. So what we see and what we see more prevalent and like to think of a bit more is the terms autoimmune encephalopathy, secondary to infection, basal ganglia encephalitis, and these terms appear to be gaining more recognition, and because they also encompass many of these different types of syndromes and disorders without limitation to the organism or the age of the patient, and therefore it has more to do with the underlying etiology and the targets rather than identification by maybe age or organism. So let's take a little step back and talk about what is PANDAS. So PANDAS was defined by Dr. Susan Swedo and published with the first 50 cases in 1998. And they were studying many children who had sudden onset of obsessive compulsive disorder preceded by a strep infection. It's been identified or believed that PANDAS and PANS may make up 1 out of 150 to 1 out of 200 children. So there are different criteria for these two different, one's a disorder, one's a syndrome, is that 5 diagnostic criteria needs to be met for the PANDAS diagnostic criteria. It's the presence of or a tic disorder, of course, prepubertal onset, meaning in children, an acute symptom onset, relapsing remitting course, meaning an acute typically is thought of as somewhere between 24, 48 hours, maybe a few days, and then a temporal association between group A strep. Well, the challenge is that probably between 95 and 98% of children do get streptococcal infections. So this has also contributed in the past to some of the controversy as to how can strep actually be the causative agent of PANDAS. But as we know that it is also in the context of individuals with the susceptibility, plus we'll show the presence of these antineuronal antibodies. So the PANS diagnostic criteria, which includes PANDAS and other organisms, is that there's an abrupt onset of OCD or severe food intake or fear, restriction, and this tends to be an OCD such as fear of food contamination or fear of choking. And then the current presence of additional neuropsychiatric symptoms with an acute onset, at least 2 of the following. You can see anxiety, emotional ability or depression, irritability, aggression, oppositional defiance or oppositional behavior, developmental regression, deterioration in school performance, even sensory and motor abnormalities, or other symptoms like sleep disturbances, enuresis, or urinary frequency, and is not better explained by some other condition. The average ages of these are somewhere between 6 and 7 years old, and boys outnumber girls about 2.5 to 1. So other studies have been published showing that there's an association with inflammation in a portion of the brain in children that have OCD and tics that are associated with a streptococcal infection. And these tend to be found in the area of what's called as the basal ganglia. And so this is identified in the caudate and inflamed in the putamen and the globus pallidus, which are parts of the basal ganglia, but not in the thalamus, which is not considered to be part of the basal ganglia. So what is the basal ganglia responsible for? It controls voluntary motor movement, procedural learning, cognitive functions, emotional functions, and eye movement. So you can see the connection here in maybe motor or vocal tics, some of the behavioral, the learning, cognitive functions, the emotional functions such as rage, other types of depression, things like that, including suicidal ideation, which is frequently observed in patients with these conditions. So dysgraphia is another condition that's often observed in patients with autoimmune neuropsychiatric disorders like PANDAS and PANS. This is a drawing that of a patient provided prior to they had motor tics, and then subject after they had motor tics, and illustrates how this impacts fine motor movement and other types of learning skills, concentration. So how does this occur biologically? Well, the journal did help explain some of that. We mentioned about microbial, viral, fungal infections that we all get, where no one's immune to that. Our body produces antibodies, and then they recognize these infectious organisms. You've probably learned a lot about that just with the SARS-CoV-2 pandemic. So, but the antibodies that these patients produce are against epitopes that cross-react with neurologic receptors through the process we mentioned as molecular mimicry. Once that occurs, these antibodies then can cross the blood-brain barrier, as was mentioned in the journal article, and they actually will interrupt parts of the brain and the functions, the normal functions, in particular these we mentioned, but I haven't shown here, but there's been publications showing that they actually bind to and react to that part of the brain called the basal ganglia, resulting in neuropsychiatric symptoms, including anxiety, aggression, rage, OCD, and the symptoms that we had described in PANDAS, PANS, and these other types of autoimmune encephalopathies. As I mentioned, symptomatic treatment is one of the components. And again, for these conditions, though, when the underlying root etiology is immune-mediated or infection-triggered, often these patients will be and can be treatment resistant to this, and in some cases actually get worse with many of these medications. Now we know that there's SARS-CoV-2 also has been triggering these autoimmune neuropsychiatric syndromes, including other targets like the heart, where antibodies and the immune system is creating inflammation like myocarditis, cardiovascular conditions, and even fatigue, what we call long COVID, and chronic fatigue-like syndromes. And what is becoming more and more clear is that it is a result of an active or an overactive immune system or a dysfunctional immune response. In fact, 1 in 3 COVID-19 patients after 6 months are diagnosed with some type of neuropsychiatric condition, is published here by The Lancet. Almost 250,000 survivors were looked at in a cohort study and found that this is about a third of them are later diagnosed with some form of neuropsychiatric condition. In addition to that, long COVID, as you've heard about, includes fatigue, but also it looks very much like and has symptoms similar to chronic fatigue syndrome or myalgic encephalomyelitis. And this may and should help more understanding of these conditions, because if you're familiar with that history, a lot of that was believed to be maybe more psychological than anything else. So as you can see here, studies have shown that can lead to things like this. And it's not the first coronavirus to do this. In fact, even early the SARS, instead of CoV-2, we call that CoV-2, it's actually SARS-CoV-1, which actually, because it wasn't so widespread, there are still reports of showing very similar symptoms, such as myalgic encephalomyelitis. One of the things that we have identified, and it is not yet published, but there is sequence homology that we've identified between the dopamine D1 and D2 receptor and the spike protein of the SARS-CoV-2. So if you look at the outer surface protein to the dopamine D2 loop, 1 and 2, there are actually 7 loops that go through here and traverse the membrane of the cell, and that there is some sequence homology where you see the green between the SARS-CoV-2 protein and the top sequence, which is the D2 loop, or the dopamine receptor 2, which we'll talk about in just a little bit, about when antibodies are directed against them, what kind of symptoms do we typically see. So now we'll move to how the targets in the Cunningham panel can be utilized to help diagnose and direct treatment to patients with immune-mediated neuropsychiatric disorders. So this is the Cunningham panel report, which is really just an aid in the diagnosis of autoimmune encephalopathy and basal ganglia encephalitis. These are the targets that we look for, antibodies that are directed against these 4 targets: dopamine D1, D2 receptor, lysoganglioside GM1, and tubulin. And this particular assay, which is a cell activation, which stimulates, the antibodies actually stimulate this enzyme in brain cells to upregulate different neurotransmitters, which we'll talk in just a second. So before we go there, how is actually the test ordered and results processed? Well, the first thing, which is important, a patient will visit their healthcare provider, and then the healthcare provider will order the panel. And we require a physician or a healthcare provider to order the panel because we also want the patient to be treated and properly interpreted as the results. There's 2 red top tubes that blood are collected in, and they are sent to us via FedEx. The pricing of the panel is $9.95 and the deposit is $4.95. Actually, that'll go in effect July 1. And one thing is that even though the cost of the test are high, it still yet doesn't cover our costs. And so therefore we raise money to try to be able to continue our work and research. But one thing here is that He Who Laughs has had a fundraiser, and they do have a small fund that is to help financially some patients who are unable to pay for the entire test to help defray it. And if you're interested in information about that and you meet the qualifications there, you can reach out to them at admin@hewholaughs.org, and there'll be more information later. So the specimen come to us overnight via FedEx, and we'll pay for the shipping. It will be run against 5 different brain targets, which takes about 2 to 3 weeks. It used to take us 6 to 8 weeks. It's down to 2 to 3 weeks. Our goal is to try to find and work on ways that it can be done within a week or less. But these are highly complex assays, and actually one of them is a radioisotope assay and grows up human brain cells in culture. The results are then uploaded into a secure portal. The results look like this, and we'll talk a little bit more about the results. We do bill on behalf of the patient as a courtesy under their insurance, if they have insurance. And often if the insurance covers a very large amount or the full amount, we'll reimburse part or all of the deposit. But if it doesn't or goes to deductible, we'll bill the remaining. The results go to the physician online, and they can contact us and do contact us for assistance or guidance in some of the results and their interpretation. So let's go to the symptoms that are associated with this. We've now tested over 13,000 patients since we've been open, various diagnoses, but when they're positive, we see various correlations with different types of symptoms. So what you see here is the dopamine D1 and the dopamine D2 receptor that is in the cell, or at least it's intracellular, in cartoon form. Antibodies can interfere with these receptors, and these receptors are important to transmit nerve and impulse and different types of information from one nerve cell to the other. When an antibody is directed against it, it can either act as an agonist or an antagonist. It's not important that you know the differences between there, but one thing, an agonist is something that actually stimulates the receptor as if it was dopamine. So antibodies that can actually stimulate the receptor and act as dopamine and trigger neuronal connections is not something you typically want to have. Antagonists are those that block the effect of dopamine. And so if it interferes with it, it can block the normal transmission of a neurologic transmission or the neurologic receptor. And so what we do see is dopamine D1s more so associated with the psychiatric symptoms, such as mood instability, anxiety, irritability, aggression, and in some cases psychosis. There are other types of symptoms that we find in the report that printed and sent to the clinician. You'll find these listings here on that report and even on our website. With the dopamine D2, we tend to see them associated with movement disorders or movements of various types of choreiform and other types of movements and vocal tics. So you can see here that there are other symptoms associated, but the most prominent one that tends to be associated with some type of movement. Antibodies that we find that are directed against tubulin, which is highly concentrated in brain cells. This particular article here showed that tubulin wasn't just a scaffolding protein in which you see up here. It actually was responsible for many types of neuronal conduction. And so where there was a mutation in the gene, they found that they were dystonia, ALS, and autism, and various types of disorder, which makes sense that if you have antibodies directed against them, we find that they're associated with obsessive compulsive disorders and things like brain fog, where patients have difficulty focusing and concentrating. There are others that have been associated with antitubulin antibodies, and you can see those here. But principally, we see these cognitive interference and what we think of as brain fog. So when an antibody is directed against what we call lysoganglioside GM1, which is contained within the myelin sheath around the nerves, again, think MS, where we find that it's associated with tics. It tends to be correlated with tics, complaints of joint and connective tissue complaints and pain. But again, you see sleep disturbances and OCD and other sensory abnormalities. So the fifth assay, which is much more of a complicated assay in that we grow human brain cells, not the patient's brain cells, but a continuous cell line that's grown up in culture, and we incubate the patient's blood, the serum from the blood, which, if antibodies are present, they will bind to the cells and that they will stimulate this CAM kinase activity. And why is that important? Well, this enzyme actually is responsible to upregulate the synthesis of dopamine, epinephrine, and norepinephrine. So an antibody that actually can activate an enzyme that calls for the upregulation of these neurotransmitters is something that is really not something you would want to see. We typically see that with the association of calmodulin CAM kinase 2 associated elevated levels, this adrenergic type of sympathetic nervous system activation, fight or flight, the separation anxiety, urinary problems, bedwetting, and even you think of dilated pupils, mydriasis, in which the dilation of the pupil is controlled by the autonomic nervous system. When CAM kinase is elevated, you can actually see that that is also one of the symptoms that you can find in these patients. Other symptoms, I mentioned involuntary movements. The other thing that is interestingly associated with this is that we do find that in these cases where patients have positive CAM, there is an association with either an active infection or a reinfection that is likely and mostly usually subclinical, meaning they won't have or don't have disease symptoms of an infection, but if you look for it, often you will find it. And so this is one of the assays that's helpful in that regard. The other thing which we do not completely know, and we're doing research on that, is how CAM kinase is involved with the communication and network of other what's called G protein coupled receptors, like the NMDAR receptor, the voltage-gated calcium channel receptor, and all these other receptors that do, like GABA, interfere with neurologic conduction. And so there's some mechanism in which this enzyme is involved, and we're also doing research to help understand that better. I'm going to shift just briefly here to a publication that was completed in February of 2022, or published in 2022, and that is when we looked at patients that had 2 or more Cunningham panels tested, and we looked at whether after their treatment that they improved or did not improve, and to see what the association was of those autoantibodies, the presence of them, with the presence or absence of the symptoms, and what kind of correlation from a sensitivity and specificity standpoint were there. What we found, as we see, is that there were various infections that were identified in these patients, and you can see many of them. There were multiple infections, and this list actually is longer than that. All the patients in both group 1 and group 2 combined, you can see here, they had almost identical, very similar symptoms, and described because they were all either diagnosed or presumptively diagnosed with PANDAS or PANS. So when we looked at the pre-treatment test results with the panel on patients who improved after treatment later, what we found is that all of the patients within this group had one or more elevated test results in one of the 5 assays, which is why we run all 5, because we don't know which antibody target is going to be positive. And if we didn't, we would miss some of these patients. Of those that got well or improved, you can see what happened after their treatment results. The patients that improved, their post-treatment results indicated dramatic reduction in all their testing results, and likely those that were improved needed to improve even more and likely would see even greater improvement based upon the direction in which these test results were going. So you can see that the number of positive tests went dramatically down, as well as the heat map indicating the degree of positivity of those tests. So in the second group, what we found before they were treated, all of them, not all of them in this case, had positive results, which was interesting because we find that sometimes it takes a while for these antibodies to come up. But what we did see, even in this case when they were treated, and this wasn't a treatment study, but it was looking at whether or not the patients improved. In fact, we did see that almost all of them then began to continue to develop these antibodies, and the elevated levels of these antibodies and the correlation with the symptoms compared to those that improved as opposed to those that didn't improve. And you can see the increased number of positive tests, the increased elevation of the existing tests, and the correlation with these antibodies. What we did was identified a sensitivity and specificity of 88% and 83% compared to symptoms, with an overall accuracy of 86% in separating these patients from those from symptoms with those before and after, with and without antibodies. We're working on a logistic regression algorithm that would specifically weight these tests in a different manner, and that is being worked on right now, and preliminarily we're able to get the accuracy up to 90%. So more to come with that in the future as we work on that research. I'm going to share just a couple of case studies real quickly here as we get close to wrapping up here. We have hundreds of these case studies of before and after treatment. This is a 24-year-old young man. He presented with OCD and tics. He lost 30 pounds, which again is not necessarily an anorexia, but a food phobia or a fear of contamination or choking. And he lost, of course, lots of weight, inability to concentrate, behavioral regression. He had one positive, and again, this was the CAM kinase positive. The patient was treated with IVIG and plasmapheresis, resulted in all his symptom reduction, and then all his antibodies returned to baseline. This is a 9-year-old girl who had OCD behaviors and even autistic-like stimming, difficulty concentrating, sensory abnormalities, emotional ability, bedwetting, dysgraphia, and you can see here 2 of them were positive with 1 borderline. I think this patient was one that was actually identified early on. The patient was treated with azithromycin, rapid improvement in the symptoms. All her antibodies had gone back to baseline. A third case, another 9-year-old girl who presented with unknown origin of neuropsychiatric symptoms. She was known to be presumptively diagnosed with Lyme based on her presence in a tick-borne area and Western blot positive. She even had a lot of problems saying that something's wrong with her brain. 3 of the antibodies were positive, and then she was treated with a fair amount of different types of anti-infectives due to the Lyme, IVIG, and complete symptom regression. And post-testing, all her antibodies resolved. This is one more 9-year-old young man, 30 days after a strep infection with OCD tics. He couldn't concentrate, separation anxiety. He also started bedwetting, dysgraphia. One of his antibodies were positive in this case, And then the patient had one IVIG, and within 1 month, complete symptom elimination, and all his antibodies returned to normal. I won't spend the time, but if you're interested, there are numerous published research and clinical papers using what we need to be sure of is that they're validated collection tubes, because the collection tube is important in that there wouldn't be any interfering substance or potential substances within the tubes. So which is why we have the red top tubes, that we have collections that are that are sent out with the tests. So let's wrap up here with the therapeutic modalities that have shown some effectiveness in patients, and I'm not going into great detail on them, but let's just say for now that they fall into these 4 categories. They're anti-infectives. Remember, the infection or subclinical infections need to be treated. Anti-inflammatory, which you're looking at the inflammatory impact or the effect of the immune system, and then things that can modulate the immune system. And then temporary symptomatic treatment relief. They can be steroids, NSAIDs, plasmapheresis, IVIG, even rituximab, and then symptomatic treatment like low-dose SSRI, cognitive behavioral therapy. If you're interested and are a clinician, you can download the Journal of Adolescent and Psychopharmacology in 2017. There's a complete list of some of the best practices for taking care of patients with these at different levels. And in fact, the PANDAS Physician Network has identified a little bit better on their website how treatment for mild, moderate, and extreme cases. That's also outlined in the 2017 Journal of Child and Adolescent Psychopharmacology. So the overview of this is that PANDAS and PANS diagnosis and treatment is you rule out the other causes or potential causes, identify and treat all the infections, whether they're viral, bacterial, and even some fungal, provide as symptomatic relief as necessary in order to manage the symptoms, but then treat the inflammation and the immune dysfunction if that's necessary. And this is just the tip of the iceberg. We believe that this is the case, that many other disorders are involved in this. And for those of you who are physicians and patients with these chronic autoimmune encephalopathies, unfortunately, you may feel like this, that the world is saying, never ever think outside the box. But as you can see, there's good science and medical help in this area. I'm going to close with this story. This is Grace, who really can barely see her very well. It's a video who she was actually asking her parents to kill her. They emptied out their 401k twice with no answer, or 401k twice with no answers. We tested her. She received proper treatment. Again, this was years ago. Recently, her mother sent us this picture of her on the cheer team and back to normal and completely well. So here are some references. We'll make sure that this is posted and available. There's some from parents. There's some from physicians. These are some good books and even a DVD. So that my kid is not crazy following 3 or 4 families through this journey. I'm also going to leave one more reference. This is for brain research. The PANDAS, PANS, and other neuroimmune disorders called POND. There's a brain bank at Georgetown University, and it was supported and is supported by the Alex Manful Fund, in which this is Alex, who the loss of her life due to this PANDAS and PANS. There's some information here. And with that, I want to thank you for listening, because our mission is to bring hope and healing to those suffering with these disorders. Also want to thank April and John for their foundation, and certainly, of course, for Isaac, for the one who actually is inspiring this. And then over 13,000 patients who've tested and treated, and then our scientists and laboratory staff and Dr. Cunningham's lab and their staff there. And so thank you for listening. I'm going to end there. And I do think maybe we have time for questions, April.
Yeah, I think we have a couple minutes. Thank you for that. That every time we watch it, I always learn something a little bit new that I didn't quite catch the last time. So I appreciate you sharing. One of the questions that we do have is whether or not the Cunningham panel is something that you have found pediatricians readily request, or is it something that the parents really need to advocate for on behalf of their child?
Yeah, that's a really kind of a delicate situation, because as with change in medicine, often it takes time. It certainly has been helpful when parents have recommended it, and the clinician would want to have maybe a consultation and talk with us. And we find that they've been very receptive, and then they begin identifying other patients. In some cases, if the physician is resistant to it for whatever reason, we do find that sometimes it may be more helpful to find a physician who can and believes or understands and has had success in treating these patients. Unfortunately, the patients that we have tested and this study will show that patients have seen between 5 to 15 doctors before they get a proper diagnosis, unfortunately, or they find out about testing and treatment. So our goal is to try to hasten that, as is yours,
Sure.
but work with your physician, help educate them. If they're open, then yes, they certainly would be willing to do that.
Is it something, I know that it has periodically come up in conversations I've had with people. Is there a collective resource that shows who are in areas that are physicians that are identified to being open to this particular topic or servicing this need?
That's a great, really good question and very important need. We do know of some, and so sometimes we can help. There are also other groups who are becoming aware of that and know about that, like the PANDAS Network and the PANDAS Physician Network. Hopefully one day there'll be a repository of names and physicians who are open to and actively taking care of these patients. But right now, it's a little bit more of finding different resources, but we certainly can help. Those other groups I mentioned can also help, and then contacting them directly.
Wonderful. I know one of the questions when you talk about the Cunningham panel is for individuals who are, as you talked about the different psychotropic medications, how do those medications, if at all, do they interfere with the actual panel results of what you're seeing when the test is completed, or is it not relevant in situations?
Yeah, that's a good question. We do not see that those interfere with the serum autoantibodies that we test for. If the patient really has an autoimmune condition that's infection triggered, they still would likely be struggling with that, even though they may be on many of these neuropsychiatric drugs. But as far as getting the test results and interfering with the test results, we so far have not seen that that's the case.
Will antibiotics alter the test results, or does it depend on the type of antibiotic the person perhaps is prescribed?
To date, we don't see that antibiotics impact the results. Now, if a patient symptoms resolve because of the antibiotics, meaning that the infection is actually under control and the immune system's not making more antibodies, then definitely we'll see the result, or we won't see the antibodies. Not because the antibiotic is interfering with it, and more likely if it is working and reducing the trigger for those autoantibodies. Because again, we're measuring the autoantibodies. Now, the ones that can interfere are intravenous immunoglobulin, because it is actually immunoglobulins that are from over 1,000 patients. So those need to be cleared, or other immunosuppressive drugs like prednisone or things that are anti-inflammatory that are really immune suppressive, because of remembering we're trying to measure the current level of circulating antibodies, and if there's something that's suppressing them or something that's either getting rid of them or interfering with that, then those could have the potential to do that. Now, a physician would be the best one to determine when they would, but we do recommend that a fair amount of time lapse when a patient is off those immune modulating drugs.
Earlier in the presentation, you were talking about the effects of long-term COVID, the 1 in 3. And I know, as you pointed out, that for so long with the PANS and PANDAS, it is focused on the pediatric population. Is the Cunningham panel, especially in light of COVID, is it beneficial for young adults to consider testing?
That's a really, I think, a very important question that we're attempting to answer, as well as Dr. Madeline Cunningham's lab. We do see in preliminary results that patients with long COVID that have these neurologic, psychiatric, and behavioral issues do tend to be positive for the panel. There's another group of targets that we are working with, along with her, is that these autoantibodies that are directed against the heart.
Mm,
And so these two panels very likely could be something in the future that we hope would be something that will help identify the long COVID patients and ultimately help direct treatment, or help to develop treatment algorithms that will predict which treatments will be
mhm.
effective.
Do you think that as obviously we make advancements and things move forward, uh, will it eventually become a conversation that it's not just about our children, but really it's something that we might see if truly if people were readily tested and it was available, we would probably, I guess, would maybe be surprised at the amount of people that would maybe show positive?
Yeah, yes. Like I said, we've tested over 13,000 patients, and we see the vast majority of them positive, likely because it's a biased group, because
Mm,
they've seen 5 to 15 doctors. But our goal in the future is that once a patient is symptomatic, that the first test would be, is this autoimmune or is this psychiatric in
mhm,
nature? And then that would direct the rest of the therapy, rather than a long period of time of trial and error on multiple psychiatric drugs, and maybe to find that this is not working, or maybe something that could happen that would not be, it would be harm for the patient, or things that could do that maybe would be difficult to undo.
sure. If I can, just one more question. I know that your time is valuable. Um, a lot of times I know I've heard in opening up these discussions and talking more readily about our experience and when we fundraise is we'll hear individuals share that their children's symptoms, the symptomology actually gets worse when they have even just a cold. And I guess I would just be curious, a cold isn't the same as like a strep virus or even COVID. So why would the symptoms actually, even with a cold, why would they have those flare ups?
Yeah. No, if you think about the mechanism that I described there, there is a causative agent that's stimulating the immune system, and in this case, it happens to be infections. So the immune
Okay.
system is being stimulated. So with a cold, it's the rhinovirus family. There's hundreds of rhinoviruses. In fact, coronavirus is also a cold family of viruses, that they're stimulating the immune system. And this is the belief that any additional infections that may stimulate those B cells to even work more or produce more antibodies. In cases, you can see where you can see aggravation, or maybe a reactivation of that. And that is part of what the immune modulatory components are trying to address, because you still have these long term memory B cells. And
Hmm.
so if you get another infection and it stimulates those B cells, then you've got additional antibodies that are made again.
As time goes on and as medicine truly makes advancements, is there any advice for individuals? As you said, they sometimes go through multiple visits without receiving the correct diagnosis, without getting the right support. Is there a particular doctor or a starting place that you would recommend for somebody who maybe is truly starting this path that has no knowledge of what's available or even where to go? Like, where would be the best place to start?
Yes, so the goal is to try to shorten that cycle to treatment, and that's knowledge.
Mm-hmm.
And so organizations like yourself, the PANDAS network, PANDAS Physician Network, the Manful Found, all of these to help educate, so patients can then immediately talk to someone who would say, yes, that sounds like my child, or
Mm-hmm.
what did you do? And then they can be helped and circumvent all of that journey to
Mm-hmm.
get to the right answer quicker because patients then can recover faster. And that's what our goal is to try to help and then bring the diagnosis to them. And then as more and more physicians become aware of it, that they can treat them quicker. So what you're doing, what the other groups are doing are impacting the lives of so many people.
Dr. Shimasaki, I would like to thank you and all the individuals that have helped make this evening possible. I greatly appreciate your time and sharing the work that you're all doing. It's quite valuable, and I'm always excited to see how we keep moving forward so other individuals can live healthier lives.
Thank you, April, and for what you guys are doing. And it's great, as you know, to hear and see the recoveries of these children and these patients that are no longer suffering from that. So we're always here to help. If anybody has any questions, don't hesitate to reach out or go to our website.
Thank you. Thank you, everyone. I'm going to go ahead. We will conclude, and feel free if you have questions. Feel free, you can put things in the chat box and I'll check here in a little bit, but have a great night, everybody. Thank you.